students, welcome to MOOC's program on drugs acting on bloods. We have already discussed drugs acting on blood part 1, that are hematinics. Today we will be discussing coagulants and anticoagulants. This is part of unit 2 of subject Pharmacology-II. Subject code is BP503T. Myself, Gitika Mehta, Assistant Professor in Pharmacology at Rajkumar Goyal Institute of Technology, Pharmacy, Ghaziabad. So, first we need to understand what is coagulation. So, hemostasis, he means blood and stasis means to stop. Sudden stoppage of blood from the damaged blood vessel is known as hemostasis. As we know, whenever there is a cut or the prick, so bleeding starts and this bleeding stops within few seconds to minutes, and this spontaneous arrest of bleeding is known as hemostasis, and this hemostasis involves three basic mechanisms. So, they are the three basic mechanisms which prevent blood loss. First is vasoconstriction, that is vasospasm of small capillaries. Second is platelet plug formation. So, at the site of the damaged blood vessels, platelets gets activated and they form a sticky plug to stop the bleeding. And further, fibrin stands at the form. Third stage is the formation of the fibrin through the blood clotting. So, fibrin stands at the form and they form a network to form insoluble complex. They form an insoluble complex. So, now what is blood clotting? It is a complex process of enzymatic reaction in which clotting factors activates other clotting factors in a fixed sequence until a clot is formed. So, number of clotting factors are required for the blood clotting, and these clotting factors are, these are proteins which are synthesized in liver. So, now we need to understand different stages of blood clotting, that is coagulation. These are intrinsic and extrinsic pathway, thrombin formation and fibrin formation. So, this flow diagram shows how clotting occur. So, there are the two pathways, intrinsic pathways and extrinsic pathways. This whole flow diagram is showing how one clotting factor activating an other, thus cascade of clotting factor results in the blood clotting, that is results in the formation of fibrin threads, that is clot. So, intrinsic system, that is present inside the blood vessel, whenever factor 12 comes in contact with the damaged blood vessel, whenever factor 12 comes in the contact with the damaged blood vessel, this gets activated. So, activated factor 12A will active factor 11 in the presence of high molecular weight kininogen, and this factor 11, activated factor 11 will activate factor 9 in the presence of calcium. Calcium plays very important role in blood clotting. This activated factor 9A in the presence of factor 8 and in the presence of platelet, phospholipid and calcium will further convert factor 10 into activated factor 10. This activated factor 10 in the presence of factor 5 and the calcium will convert prothrombin into thrombin. Prothrombin is factor 2. So, it will convert factor 10 A will convert prothrombin into thrombin. Thrombin will further convert fibrinogen into the fibrin. These are the soluble, and this fibrin is get stabilized in the presence of stabilizing factor, that is factor 13 and thrombin to form insoluble fibrin threads, that is our clot. So, this is clot. So, there is a network of fibrin threads form along with the platelets, and this network of fibrin threads is known as clot. In extrinsic pathway, this is the rapid pathway and this is the slow. In extrinsic pathway, as soon as the damaged tissue come in contact with the factor 7, factor 7 gets activated. Factor 7 in the presence of tissue factor and calcium will convert factor 10 into factor 10A. So, basically this activation of the factor 10A, it is the common step. It is the common step in both pathways, intrinsic and extrinsic pathway. So, this further factor 10A will activate a conversion of prothrombin into thrombin. Thrombin will convert fibrinogen into fibrin and this fibrin in the presence of factor 13 and thrombin will form fibrin thread. So, this is cascade of blood clotting. So, what are the coagulants? Coagulants, these are the drugs that promote coagulation and control bleeding. Coagulants, these are the drugs that promote coagulation and control bleeding. Coagulants are known as hemostatics. They are also known as hemostatics, that they stop bleeding. They can be used systemically or they can be used locally. Local coagulants, they are also known as styptics. They are also known as styptics. Coagulants, they are used to control bleeding in hemorrhagic states like hemophilia and von Willebrand's disease. Though fresh whole blood or plasma is the best therapy for the blood loss in the hemorrhagic states, because fresh whole blood provides all the factors needed for coagulation and also whole blood acts immediately in the emergency situation. Now, further we will classify coagulants. So, vitamin K is most important coagulant. So, vitamin K exists in 3 forms: K1, K2 and K3. K1 is obtained from plants, that is known as phytonadione. K2 is produced by the bacteria in the gut and K3 is the synthetic vitamin K that is present, that is synthesized as fat soluble derivative and water soluble derivative. Fat soluble is menadione, acetominophenol, menadione sodium bisulfite, menadione sodium diphosphate. Other coagulants are human fibrinogen, anti-hemophilic factor, desmopressin, adenochrome, monosemicarbazole, ethamsilate, etc. Now, first we will understand pharmacology of vitamin K, that is how it produces coagulant action. So, vitamin K is fat soluble vitamin required for the synthesis of clotting factors. Dietary sources are green leafy vegetable such as cabbage, spinach and liver and cheese. Action: vitamin K acts as a factor at a late stage in the synthesis of coagulation protein prothrombin factor 7, 9 and 10 by liver. So, here we can see that vitamin K helps in the synthesis of factor 7, factor 9, factor 10 and factor 2, that is prothrombin. So, these 4 factors, they are synthesized by vitamin K in liver. So, 2, 7, 9 and 10 by liver. So, vitamin K deficiency results from liver diseases like obstructive jaundice, malabsorption, long term antimicrobial therapy, long term broad spectrum antimicrobial therapy, because broad spectrum antibiotics, they kills intestinal flora and thus reduces the vitamin K in our body. So, lead to vitamin K deficiency. So, whenever there is vitamin K deficiency, so vitamin K is responsible for coagulation. So, it will lead to the bleeding. So, vitamin K deficiency will lead to the bleeding. In that case, hematuria, that is blood in urine, is the first symptom. Apart from this, epistaxis, that is nosebleed, echinosis, that is bleeding under the skin, these may also occur. So, next is therapeutic uses. As we discussed that these are the vitamin K deficiency causes like dietary deficiency, liver diseases, malabsorption, long term antimicrobial therapy. So, vitamin K is used in vitamin K deficiency diseases in the dose of 5 to 10 mg per day orally or parenterally. Apart from this, newborn babies lack intestinal flora and they have low level of clotting factors. So, vitamin K in the dose of 1 mg intramuscularly is given at the time of birth to prevent hemorrhagic diseases of newborn. Vitamin K is also used in the overdose of oral anticoagulant. Vitamin K acts as antidote for the oral anticoagulant, that is warfarin poisoning. Other coagulants are fibrinogen, anti-hemophilic factor that are obtained from the human plasma. They are used to control bleeding in hemophilia, anti-hemophilic globulin deficiency. Desmopressin, which is vasopressin analog, checks bleeding in hemophilia and Wallbild's disease. Adenochrome monosemicarbazole, ethamsilate, they correct abnormalities of the platelet adhesion and they are used in the prevention and treatment of capillary bleeding in menorrhagia, postpartum hemorrhage and epistaxis. So, that was the coagulant that are used systemically. These are the coagulants that we can use locally and at the approachable sites. So, local hemostatics, they are also known as styptics. They control bleeding from local and approachable site. So, they are used during the tooth extraction, abrasions and nasal bleeds. So, these are the few examples of local hemostatics: adenal solution which arrests bleeding by the vasoconstriction, thrombin powder, fibrin sheets. Thrombin powder is obtained from bovine plasma, fibrin sheets are obtained from the human plasma, gelatin foam, thromboplastin powder and 1% tannic acid which act as astringent. So, these are the agents which are used to control bleeding locally. So, we have covered coagulants. Now, we have come to the anticoagulants, that is these are the drugs which reduce the coagulability of the blood, that is. So, they are either can be used in vivo, that is inside the body, or the in vitro, that is inside the lab. So, in vivo anticoagulants, these are parenteral anticoagulants and oral anticoagulants. Parenteral anticoagulants, they are the indirect thrombin inhibitors, in which most important is heparin and low molecular weight heparin. Direct thrombin inhibitors, lepiridine, bivalirudine, etc. Oral anticoagulant, coumarin derivatives, most important, that is warfarin sodium, indane derivative, phenindione, direct factor 10A inhibitors and oral direct thrombin inhibitors. The example are dabigatran, etc. So, these are the anticoagulants, parenteral as well as oral, which can be used inside the body. So, these are the few example of the anticoagulant that we use in the lab while collecting the blood sample or during the blood transfusion. So, heparin 150 unit to prevent clotting of 100 ml of blood, calcium complexing agent sodium citrate 1.65 gram for 350 ml of blood used to keep blood in the fluid state for the transfusion, anticoagulant acid citrate dextrose solution, blood for investigation we use sodium oxalate and sodium aditate. Next is heparin. So, this is the parenterally used anticoagulant and this is most powerful anticoagulant because it is extracted from liver. So, it is named as heparin. Heparin, hepatocytes, you must have listened hepatocytes. So, hepatocytes, because it is derived from the liver, so it is named as heparin, and it was discovered first by a medical student named MacLean in 1916. So, heparin is a powerful anticoagulant. It is a mixture of mucopolysaccharides with molecular weight of 10,000 to 20,000. So, polysaccharides are D-glucosamine, L-iduronic acid and D-glucosamine, D-glucuronic acid. These are the mixture of mucopolysaccharides. Heparin is the strongest acid, organic acid present in the body, and it is found in the mast cells of liver, lung and intestinal mucosa. Commercially, it is obtained from ox lung and pig intestinal mucosa. Next is mechanism of action of heparin. How does it act? So, heparin instantaneously acting anticoagulant that it acts immediately and effective both in vivo and in vitro. So, heparin binds and activates plasma antithrombin 3. So, heparin binds with antithrombin 3, and this heparin antithrombin 3 complex binds to clotting factor. Various clotting factors, they binds to activated form of the various clotting factor, factor 10, 2, 9, 11, 12 and 13, and after binding it inactivates them. So, this complex heparin and antithrombin 3 complex inactivates various factors of intrinsic and common pathway. So, what will it result? It will result in the inhibition of factor 10 as well as thrombin, and thus it will inhibit conversion of fibrinogen to fibrin. So, fibrin will not form, then there will be no clot. So, thus heparin produce anticoagulant action. So, there will be no clot. Okay? So, heparin binds and activates plasma antithrombin 3. This complex will further inactivate various clotting factor that would result in the inhibition of factor 10 and thrombin, and thus it will prevent the conversion of fibrinogen into fibrin, and thus there will be no clot formation. Fibrin threads will not be formed, thus it produce anticoagulant effect. Heparin in the large dose, at high dose it inhibit platelet aggregation. So, it also produces antiplatelet action at high dose. It also clears blood lipid. It reduces the blood lipid level by activating lipoprotein lipase. So, it is responsible for lipemia clearing. Lipemia means emia for blood, lipid it is for lipid. So, it clears blood lipid level by action of the enzyme lipoprotein lipase. Pharmacokinetics. So, during heparin therapy, partial thromboplastin time is about 1.5 to 2.5 times the normal value. So, partial thromboplastin time is prolonged. So, monitoring of this PTT time is required. Partial thromboplastin time. Heparin is large molecular weight, highly ionized molecule. So, it is not absorbed orally. If injected intravenously, it acts immediately, but after subcutaneous injection, anticoagulant effects develops after 60 minutes. It does not cross blood brain barrier, neither it cross placenta. So, as it cannot cross placenta, So, it is safe in pregnancy and metabolized in liver by heparinase. So, what are the adverse effects? So, in the overdose, when there is a overdose of heparin, it will lead to the bleeding because it has anticoagulant action. It will prevent the clotting of the blood. So, when there is no clotting, so bleeding will occur due to the overdose of heparin. So, that is the serious complication and that will appear as hematuria. So, that is the first sign, that is bleeding in urine. Another is thrombocytopenia, as I have told that it causes the platelet aggregation and formation of antiplatelet antibodies. So, it will cause mild and transient temporary thrombocytopenia, means deficiency of thrombocytes, platelets. Thrombocytes means platelets, penia means deficiency. So, they will reduce the number of thrombocytes. So, we should stop heparin whenever there is the thrombocytopenia. Transient and reversible alopecia, that is loss of hair, osteoporosis on long term use, hypersensitivity reaction, that is heparin may produce allergic reaction. So, heparin is contraindicated wherever there are the bleeding disorders, heparin induced thrombocytopenia, ulcer in gut and endocarditis. So, these are the conditions where we should not use heparin. Other is, next is low molecular weight heparin. Low molecular weight, they have mechanism similar to that of the unfractionated heparin. The only difference is these are commercially prepared by fractionation of unfractionated heparin. So, they have molecular weight, they are low molecular weight with the 3000 to 7000. Examples are enoxaparin, deltaparin, tinzaparin, panaparin and reviparin. Mechanism of action is similar to heparin, but they selectively inhibit factor 10A with little effect on factor 2A. That is, they first induce conformational changes in antithrombin 3 and then inhibit factor 10A and with little effect on 2A. As a result, low molecular weight heparin have small effect on PTT time. So, it has advantages over conventional heparin. It has better subcutaneous bioavailability, they have predictable pharmacokinetic profile, they have longer duration of action. So, once daily dose is quite sufficient, lower risk of the bleeding, they have less interaction with the platelets. So, less chances of the thrombocytopenia and lower risk of osteoporosis. So, low molecular weight heparin, there the molecular weight is 3000 to 7000, mechanism of action is similar to that of heparin, but they selectively inhibit factor 10A and they have benefits, they have advantages over unfractionated heparin because they have better pharmacokinetic profile. So, next is uses of low molecular weight heparin. They are used in the prevention and treatment of venous thrombosis and pulmonary embolism. They are also used in unstable angina. So, they are used to prevent the formation of clot and to maintain the patency of tubes in dialysis patients. Heparin antagonist. So, whenever we need to stop the action of heparin rapidly or in case of the heparin overdose, we need to give heparin antagonist, that is protamine sulfate. So, protamine sulfate is heparin antagonist given intravenously to neutralize heparin. 1 mg of heparin for every 100 unit of heparin, 1 mg of protamine for every 100 unit of heparin. So, antagonist protamine is used when heparin action needs to be terminated rapidly and in heparin overdose. So, this is a strongly basic protamine which binds to the acidic heparin and form an inactive complex. Thus, protamine neutralizes heparin and terminates its action. So, heparin antagonist is protamine sulfate. Other are fondaparinux, which is synthetic derivatives, inhibits factor 10A by binding to antithrombin. Others are direct thrombin inhibitors, they bind directly to thrombin and inactivate it without the need to combine with and activate antithrombin 3. Examples are lepidolin, bivalidine. So, these are the other drugs of parenteral anticoagulants, and next is oral anticoagulants. So, oral anticoagulant में most important is coumarin derivative warfarin sodium. It acts only in vivo, and warfarin sodium, its chemical structure is similar to vitamin K. So, it is competitive antagonist of vitamin K. In sodium, it is synthetic derivative of coumarin. It acts only in vivo. It is vitamin K antagonist. So, vitamin K antagonist is warfarin. So, warfarin interfere with vitamin K dependent synthesis of clotting factor in liver. It blocks the gamma carboxylation of glutamate residue in 2 factor 7, 9 and 10. So, here we can see warfarin blocks the conversion of vitamin K epoxide into hydroquinone, which is active form of vitamin K. So, vitamin K is responsible for the carboxylation and for the synthesis of these factors. So, in the presence of warfarin, which is competitive antagonist of vitamin K will not be able to synthesize factor 7, 9 and 10 and prothrombin. So, pharmacokinetics, they have slow onset of action. It develops gradually over the next 1 to 3 days because level of clotting factor, because it cannot act on the already present clotting factors. So, level of clotting factor present in the plasma decline progressively. It completely absorbed orally, 99% bound to the plasma protein, and it is metabolized by glucuronide conjugation. So, these are the few examples of the drug interaction, which these are the drugs which potentiate warfarin action, and these are the drugs which reduce warfarin action. Adverse effects: bleeding in overdose, alopecia. It is teratogenic, so it should not be used during the pregnancy. In case of warfarin poisoning, there is increased bleeding. So, to control the bleeding in overdose, we either give fresh whole blood or we can also give vitamin K as specific antidote. But vitamin K cannot act immediately. It will take 6 to 24 hours for clotting factors to be resynthesized. These are other orally acting anticoagulants: rivaroxaban, dabigatran. Rivaroxaban is direct inhibitor of activated factor 10A, used for the prophylaxis and treatment of deep vein thrombosis. Dabigatran, orally acting direct thrombin inhibitor. It is longer acting, rapid onset, and once daily is sufficient. So, anticoagulant uses, they can prevent the extension of thrombus, but they cannot dissolve the existing clot. So, heparin is used for rapid action, for initiation of therapy, but for maintenance therapy we can use warfarin. So, aim of using anticoagulant is to prevent thrombus extension and embolic complication by reducing the rate of fibrin formation. In case of deep vein thrombosis and pulmonary embolism, myocardial infarction, unstable angina. It is also used to maintain the patency in case of rheumatic heart diseases, vascular surgery, prosthetic heart valve and hemodialysis. So, basically it stops the formation of clot in this condition, so that blood can be flow, it can remain in the circulation and flow in the circulation easily. So, these are the references. So, in this we have learned about the coagulants, what are the anticoagulants, how do they act, mechanism of action of heparin as well as oral anticoagulant warfarin. So, I hope it is clear to all. Thank you.